Hello, everyone, and welcome to today's webinar. We are celebrating Pride Month. Today is the first part of a two-part webinar series, Tailoring Treatment for Gender and Sexually Diverse Latinx Youth with Suicidal Behaviors. Part one will be directed to describe tailored treatment for LGBTQ Latinx youth. That's today in this presentation. And part two, which will be on July 6th, will be directed to explain how to work with their caregivers. Our speaker today is Dr. Duarte Velez. She received her PhD from the University of Puerto Rico and is currently an assistant professor in the Department of Psychiatry and Human Behavior at Brown University and Bradley Hospital. She is also a licensed clinical psychologist with extensive experience with children and families from diverse backgrounds. Her research interests are to develop and tailor treatments for diverse populations, those of different ethnicities, sexual orientations, and genders, according to their needs and cultural values. Dr. Duarte Velez completed a pilot randomized trial on RCT on the SCBT-SB versus treatment as usual in real world setting with positive results. Currently, she is conducting a randomized clinical trial to test the efficacy and effectiveness of Socio-Cognitive Behavioral Therapy funded by the National Institute of Minority Health and Health Disparities. Would like to note that this presentation was prepared for the National Hispanic and Latino MHTTC under cooperative agreement with SAMHSA, Substance Abuse Mental Health Service Administration. Our network, the MHTTC network, uses affirming, respectful, and recovery-oriented language in all its activities, including this one today. And so, without further ado, I would like to hand it over to Dr. Joanska Duarte. Please welcome her for today's presentation.
Hi, everyone. It's a pleasure for me to be presenting this topic. I first have to say that I do not have any conflict of interest to disclose and that my research has been supported by NIMH, the American Foundation for Suicide Prevention, and currently by the National Institute on Minority Health and Health Disparities. The objectives of this presentation are to provide basic information about the relevance of affirmative care for LGBTQ plus Latinx youth, introduce the Socio-Cognitive Behavioral Therapy for suicidal behaviors, and to describe tailoring treatment for gender and sexually diverse Latinx youth and their caregivers. As Eric explained, I will be covering today part one, which would be directed to the work with Latinx youth, and in the second part, directed to caregivers. If anything is left, or if there's any questions that I cannot answer in this one, you could put it on the end, and then I will cover that on the second presentation. My practice and research is based on the belief that LGBTQ plus expressions are natural variations of humanity. And number two, that Latinx families can learn to support their children even if they do not agree with their sexual orientation or gender identity. And first, I always provide an explanation, a little bit about where I am or who am I, because this is the first step in working with Latinx youth and their families. The first step is to acknowledge who am I as a clinician serving this community. So I have to recognize and acknowledge my own identity, as well as that's my invitation for everyone that want to do this work. And that means to understand in terms of education, race, ethnicity, sexual orientation, socioeconomic status, preferred language, spiritual beliefs, and personal values and culture, among others, where I am on all of those, to comprehend my potential bias and how different or similar my experience may be experience and my identities, similar or different, may be from the experience of those I'm working with. In other words, I must understand those parts of my identity that make me part of a minoritized group, groups that society has placed in a position of less power and privilege, as well as those aspects that give me some privilege. So I will ask all of you that please take a minute to think about those aspects of your identity that make you part of a privileged group, and those aspects of your identity, if any, that make you part of a minoritized group. I hope you all did this exercise. And I'm showing this map because I am Puerto Rican. I was born and raised in Puerto Rico, and all my professional training was there. So at this point, I'm prioritizing my national background as one of a very important part of my identity. And other times I just prioritize others, but this is very important to me. And also the treatment approach that we will be talking today start in Puerto Rico. So the Latinx community confront health service disparities in two important ways. Number one, from my perspective, we have disparities in terms of health outcomes. Well, not just my perspective. You will see now about some data that support that there are risk factors that are higher among Latinx youth. And the other part that compounds what it means a health service disparities is the availability, quality, and suitability, and the way that care is provided. So one aspect of health disparities is healthcare outcomes, and the other has to do with the treatment itself. So in terms of disparities, talking about health outcomes, over the years, Latinx adolescents in the US have been reporting a higher prevalence of suicide attempts in comparison to their white peers, with the exception of the last two national surveys, in which no difference were reported between Latinx and white, and between Latinx and Blacks. However, Puerto Ricans on the island, the yellow line at the top, have consistently reported higher prevalence of suicide attempt than Latinx in the US. And this is a biannual national survey from the CDC. Latinx females think about suicide and attempt suicide 2 times more often than males, according to this national survey. And we have to recognize, even though Latinx females attempt suicide a lot more than males, that male youth die by suicide 4 times more often than females, and their participation in treatment is usually low. Overall, Latinx have also reported higher prevalence of feeling sad and hopeless compared to their Blacks and white peers. As you can see, the purple line at the top, that has been consistently over years. And the green line are Puerto Ricans in the island again that are close to Latinx in US. So now when we talk about sexual orientation, this same biannual national survey provide this data. Latinx females, just if we are talking about Latinx high school students, Latinx females think about suicide and attempt suicide two times more often than males, as I already said. But if we divide this by females versus male, Latinx that identify themselves as lesbian, gay, and bisexual attempt suicide significantly more. This is as a group, more than their heterosexual peers. And this is actually true regardless of ethnicity. But Latinx females, as you can see here, the blue column, who identify as lesbian or bisexual, report attempting suicide 3 times more than their heterosexual peers. Again, this is only Latinx. And Latinx males, which is the orange columns, who identify themselves as gay or bisexual, report attempting suicide 4 times more often than their heterosexual peers. Unfortunately, this national survey does not provide information regarding trans, gender fluid, or non-binary youth, who from now on I will refer to using the umbrella term trans. But data from big surveys, such as the one from the Trevor Project National Survey, that survey and other research points to a higher prevalence of suicidation and attempts among trans teens in comparison to their cisgender peers. In terms of the type of services or the availability of services, this is another disparity, as I said before. Latinx children aged 12 to 17 with a major depressive disorder receive less treatment for depression in the last 12 months compared to their non-Hispanic white peers. Latinx youth are underserved with regard to mental health care. Latinx families face barriers to accessing services for diverse reasons, including language, stigma, structural barriers such as transportation, and caregiver work hours, those among others. And evidence-based treatments for suicidal thoughts and behaviors are limited for this population. And also, Latinx are underrepresented in biomedical research and scientific workforce, which then limit the research that is specifically generated for the Latinx community. Because of all of these reasons, my research program is intended to increase equity by developing culturally relevant treatments for Latinx youth with mood disorders and suicide thoughts and behaviors. So that was the justification of this work. And how is that I determine to develop a treatment specifically for Latinx youth with suicidal thoughts and behaviors. I will not get into all the research that is behind this treatment approach. I would just say that the Socio-Cognitive Behavioral Therapy started in Puerto Rico, and it has been through different stages, which is represented in this graphic. And as I said, and Eric said, a pilot RCT was completed. That will be stage 1V, as you see there. And we are currently doing, we're already step 4, currently doing a big study, I would say, to assess efficacy and effectiveness, because we had positive results in the pilot study. And next, please. I will show you this as a summary, and everyone that would like can take a picture of this slide, so you can look for more information or look online, specifically on ResearchGate by my name, Jovanska Duarte Velez. You can find these papers, so you can read more about case studies in Spanish, in English. The treatment development is on the one that is highlighted, the yellow one. And the one that I also will recommend, because next time we will be talking about parents, I will recommend that if you could read the one that it says Jimenez Colon and Duarte Velez 222, Raising Children in Different Cultures, which will give you a sense of how we adapted for Latinx youth and families in US. So those two, if you have the chance to read it, it will be great. So as I said, the pilot study was 46 families. There will be a paper coming soon about that. We're just responding to the comments of reviewers, and it was in a real world setting, and we have positive results for depression, reducing depression at 12 months, and suicide attempts at 12 months comparing to treatment as usual. We are doing now, as I said, this RCT. The target is 160 families. We are kind of in the middle, and the information that I will show you in the next one is based on the current RCT. I have to say that we are recruiting, just so you know what's the type of population that we're working, as presented in the previous slide, is from psychiatric hospitals, partial programs, and the thing that all these youth have in common is that they went through a suicidal crisis. So they all have high suicidation, or they went through an attempt. So I will not get into this, but just most of them, of the sample that we have right now, are second generation, which means that parents were born outside of US and teens in US. Next. Most of teens of the sample and the pilot as well prefer to speak English, and most of the parents prefer to speak Spanish. The 48 of our families are low income, reporting as living paycheck to paycheck or worse. And we have a percentage that are uninsured. And the vast majority of our sample are cisgender females. However, we have a significant 17% of youth who identify as trans, gender fluid, non-binary, or not sure about their gender. This information underscores the need to feel comfortable and competent when working with teens under the trans umbrella if we are working with Latinx youth at suicidal risk. In terms of sexual orientation, yes, thank you. In terms of sexual orientation, almost 6 out of 10 reported a diverse sexual orientation, with almost a third identifying as bisexual. Again, highlighting the need to include an LGBTQ plus affirmative approach into the treatment of Latinx youth at suicidal risk. So we have there the justification and some data. And now I would like to talk about our treatment approach. From our understanding, to understand what a suicidal crisis is, suicidal ideation and behaviors, we need to see the context and our society, the values that surround us, the social norms. And if we see around us, then we could understand why teens with diverse sexual orientations and gender identities are at higher risk of suicide, right? Many of those social norms that are at the top of the circle and in red, such as patriarchy, religiosity, and machismo, support heteronormative values. In those heteronormative values usually are embraced with more intensity within the Latinx community. And heteronormative means that the attitude that heterosexuality is the only normal and natural expression of sexuality. And this also implies the classification of gender into two distinct opposite forms of masculine and feminine. In other words, you're assumed to be straight and cisgender unless you prove the contrary. And this is one of the reasons why the coming out process for LGBTQ plus community is constant, and it represents for many a tension of assessing and checking when it's safe and appropriate to disclose their sexual and gender identity. Not having to do that is a privilege that cisgender heterosexual people have. So this is the context to understand pretty well the extra situations or the difficult situations that the LGBTQ community confront. Thus, the Socio-Cognitive Behavioral Therapy is based on a CBT approach, but is embedded within an ecological framework to comprehend the interactions among personal, interpersonal, and sociocultural factors that surround us, with all those social norms in our minds, taking that into account. So those social norms and values produce biases. Social biases then produce an external and internal effect on LGBTQ plus youth and in everyone, but specifically to understand their experience, we have to talk about this, right? From the external forces, they may receive discrimination, microaggressions, and acts of aggression. But also, it is important to understand that in the same way, we all have internalized social bias because we all have in different degrees. LGBTQ plus people as well have or may have internalized biases toward their own identities. So, for example, if a kid has been raised hearing all the time messages that being gay, for example, is sinful or just wrong, when they realize that they are gay, they may certainly think that there is something really wrong about them, or hate being gay, which is internalized homophobia, or feel ashamed about their sexuality. Those internalized homophobia, biphobia, transphobia could be reflected in therapy, or certainly could be reflected in therapy in different degrees or in our interactions with the community. We also need to acknowledge that having multiple minoritized identities may lead to even higher stress, which is referred as to multiple minority stress. Okay, there are unique aspects in the experience of Latinx youth and their families that are relevant to understanding and targeting their suicidal behavior. So again, all these values combined may just intensify some of the social norms that we all have and are out there. And all those factors and norms combined with acculturation and enculturation may have an effect on the identity integration of the teen. For example, acculturation refers to the process of adopting values, customs, and behaviors of the host culture, in this case, US American culture, and of course, I'm talking here about Latinx in US. This may be different from the experience of Puerto Rican in their own country. Even though there are certain aspects of acculturation that Puerto Ricans in the island may experience as well. Enculturation refers to keeping and protecting one's own cultural values and norms, in this case, the Latinx culture. And then when we find, as you saw, that we have half of our sample or many generations that we see here, parents are more enculturated, keeping more their Latinx values, while teens grow up here in US. Sometimes there could be bicultural, having both experiences, and they are more used to hearing and relating to certain things that may feel like are more accepted in the American culture. They speak English, which give them an open door for a lot of more information, but not for the parents. Then there's a conflict there. There's a tension in many other ways that this presentation is not about that. I just have to say that all this combined affect in some way the identity integration of the teens, not only on the terms of sexual orientation and gender identity, but in many other ways that are even out of the scope of this presentation. Continue, please, for the next one. So our change model is that besides the CBT regular targets, with each thoughts, coping skill, or interactions, I mean, mostly cognitions and coping skill in the socio-cognitive behavioral therapy, the other targets are identity integration in terms of the adolescent, and then in the family, the other target is communication and support versus conflict, in the sense that depending on how much support the family could provide, accepting and validating and affirming the adolescent's identity versus how much that is a source of conflict could be the results and the outcomes and the psychological stress of this kid reduce or not, and their suicidal behavior. So, I mean, I hope that with this brief explanation of the model, then you can understand why we do the things that we do in terms of how we approach LGBTQ plus youth in this treatment. So as I explained in the treatment model, identity is crucial, not only for LGBTQ plus teen, but for all the kids that we see. And we have to say that for many teens, there's a smooth self-identity development that can happen when there is a nice integration between teens' individual characteristic and the family, the community, and the religious and spiritual values that surround them. This is the ideal, right? And we don't expect in a development of a teen that they get all the same from the parents, like that they are replica of their parents and society, but they take of them, and it's supposed to combine smoothly, or could, right? Sometimes there's tensions, of course, but for most of our LGBTQ plus Latinx kids, please next one, that integration of taking a little bit from all of those aspects is not the case. Sometimes the family values and the sexuality and the gender identity is conflicting, right? And when there is a conflict, sometimes there's this cognitive dissonance that the team may have if they feel that they are part of this family, and as well they have spiritual belief, and many times they feel they're Christian in some cases, I would have to say, and then they have a sexual orientation that is not approved or endorsed or accepted, all the contrary, rejected and criticized by the family and by the religious community that they're in, right? And this also can happen many times as well with the gender identity they have. So this is to say that for LGBTQ plus kids, these tensions could be really hard and create a lot of distress um, in the normal, what's supposed to be the normal development of their identity. This is not to say that only the LGBTQ youth experience these tensions. The tension could be between parents and youth, starting with something as simple as the career they want to choose, right? We know in this phase of adolescence that there are kids that, let's say, oh, I want to be a teacher, and then the parents want something else. And tensions could be around that. Tensions could be about how they dress. Tensions could be about how the music that they like, or the videos or type of activities they do, right? All of those things create tension, but it's not the same create tensions of things you like or want in life than tensions around your identity. This is beyond what you would like to do or to have fun. This is about own identity. So it's pretty critical in the sense that they feel support versus rejections about who they are. And this is why this is so important, and that we need to know how to address and provide affirmative care for LGBTQ plus youth. So the protocol that we provide in general, so everyone have an idea, looks like this. This is what we present to the teens and the family. It is, and I'm sorry it's in Spanish, but for some reason I thought that this was going to be in Spanish. But it says the first phase, where it says modelo de crisis, is crisis model. is like the first nine sessions, everyone gets the same. And I will discuss today is the first 3 sessions, which could give you a sense of our approach. So every teen have those 9 sessions the same. After that, then we provide different options. So everything that you see there in orange are the different models that we have. And each model could take usually like a month. It could be 4 sessions, 5 sessions, 6 sessions, depending on the need. And then the things in blue is, let's say, the reasons why you should engage in that model. For example, in the first one, say low self-esteem, negative thoughts, hopelessness. If that's the clinical features that the teen has, then the recommendation is to go to the thoughts model first after the crisis model. And then they could change interchangeably the order. It's not one same treatment plan for everyone. Every person, according to their needs, decide. And is very uncommon that any particular person could make all of this. Is sometimes is like a combination of the core model and maybe 2 more, just so you understand. But we do have a model that is specifically address identity affirmation. That's the one that says the second from down to up is identity affirmation, and the explanation is to explore sexual orientation and gender. But we're gonna discuss today not the specific model because it's impossible to do in a training like this, but we will set the base for the approach. And I hope that this may help you in your therapy. So first, we need to clarify some terms. And also, I always like to present this unicorn, the gender unicorn. Is not mine. It's not Invita who produced this. That's how Invita project is how we call our research program. The gender unicorn is out there. Everyone can look it up. And it's helpful to explain families and also even teens that are discovering or understanding themselves these different dimensions, right? So first, gender identity is explained as is how you see and identify yourself in terms of your gender, and that's here in your mind, how you see yourself, right? Gender expression, which is the green line. Oh, there, those little points that are surrounding the unicorn. It has to do with your manners, your dress, your behavior, your actions, and so on. How you present yourself into the world, right? And that could be feminine, masculine, or it can be other. It could be a combination. It could be something else, like queer or non-binary or androgynous. However, the person decide that expression may be. And the same with gender identity. Gender identity could be female, woman, could be male, could be that the person see themselves as non-binary or gender fluid, which would mean, well, I hope that you can look the terms. If I define every term, it will be really hard. But the basic here is that you understand the difference between gender identity and gender expression. I can see myself as female, but my expression could be very masculine and dress more masculine and behave as what society traditionally will say is masculine. And there's people that not even want any of those type of categories. They just reject all categorization or binary thing about female and male. And then sex assigned at birth, which I will call better gender assigned at birth, is based on genitalia and the perception of the doctors when you are born. They see you, they based on your genitalia, your gender, and that's what they assign. So cisgender people are people that the sex or the gender assigned at birth is the same as the way they see themselves in their mind. Transgender people are people that the gender assigned at birth is different from how they see themselves. That could be, again, could be if their gender assigned at birth is male and they see themselves as female, then it would be trans female. It could be as non-binary or gender fluid, any other dimension of the trans umbrella. Then physically attracted to and emotionally attracted to has to do with actually sexual orientation. There's a lot of people that confuse sexual orientation and gender identity is different. People that are trans from the trans umbrella could be straight, bisexual, pansexual, like asexual. They could identify with any sexual orientation. So those are two different things. And gender dysphoria, I just want to put that out, is a term to describe the distress and unhappiness, anxiety that trans people have or may feel about the mismatch between their bodies and their mind, their gender identity. That what it would be called gender dysphoria. So this is the first session, right? What we do in the first session, we talk and meet with the family, those that are part of the household, grandparents, siblings, if the siblings are old enough that the parents feel that could be in this session. And here are the objectives of that session, right? Establish rapport, empathy, explain treatment objective, all those, but I want to just emphasize that in this first session, we establish a safety family plan. And in that context, because I can't forget that we're talking not just LGBTQ plus youth, but also those that are at suicidal risk and that have a history of a suicidal behavior or thoughts. So we start in the context of a family session where we can go over the family story regarding the suicidal crisis. That means how the family sees what happened. You know, how is that they got into the hospital? So it's very important to have the perspective of where each family member is in terms of the suicidal crisis. And then in that context, we explain the suicidal crisis within a socio-cognitive behavioral perspective. We present this onion here that you see at the top right. We use this to explain how all of those aspects are interconnected and to identify with them possible risk factors. We circle the possible risk factors on that onion at the different levels, and we also acknowledge and recognize the strengths of the family and the resources that they have. So if, for instance, the church is a protective factor and something that have give them support, we acknowledge that as a support. If the school has been stressed because of bullying, we highlight that as a risk factor, right? So we can have a picture of where the family is, where the risk factors are overall, and where the strengths are. Very important is that we are observing in this family session how they interact and what is the understanding of each about the suicidal crisis. The suicidal crisis may be directly related to their sexual orientation and gender identity, or may not at all have to do with that. So we have to be very cautious that we cannot assume that because we have a teen that is pansexual, for example, that has to do with their suicidal crisis, or because the person is trans, it has to do with. So that's, we have to observe and listen first what they're saying. Sometimes it could be indirectly related. For example, when they, let's say one of the issues, and this has happened, I see clients myself and I supervise my clinicians doing the therapy in home-based treatment, the Socio-Cognitive Behavioral Therapy. So I have had families that they one of the issues has to do about how they dress. It's not directly related to being of any gender, but it in some way that the way they dress is related to their identity, right? Because it may not be as the family expected to be, even though they may not even know about their gender identity, right? So we have to be very open to catch these things. Another very important thing I have to say this about the family session is that we ask about their pronouns. What are the pronouns that they use? We ask that to the teen, but we do this privately. And this is because many times the teens has not come out to their parents in terms of their gender identity. And we want to respect the place that in which the teen is. We will not disclose or anyone's sexual orientation or gender identity without the person permission. So this is very important. We do go by the names that are, we already have the names in the chart, and sometimes it says the name they use, and that name is different from their first or the name that their parents gave to them. If it's that clear, that means that everyone is clear, and we go by what is there. If it says in the chart, in our case already, that they are using a different pronouns, we use the pronoun that is there. If not, we just refer to the team by their name as it is, and we wait until we are individually to ask them about their pronouns. And I mean, because you will see the next session is about identity. We explore all that there. If they are out with the parents, if not, and how they want us to navigate this with them to support them. That's the most important here, is to support their process. Is their process, not our process. So this is what we do in the first session. And obviously at the end, no matter what is happening, we try to reframe the situation in a positive way. And when I said this, even a crisis, and that's why we call our name the suicidal crisis. This is a framework that uses the idea from a crisis perspective that a crisis is an opportunity for change. Always, a crisis is an opportunity for change. So that gives you hope, just knowing that there's this situation that happened with your teen, like shake the whole family system, and now it gives you the opportunity to rearrange those relationships in a positive way for the good of everyone. We also follow a family system approach here, where we believe that each person situation affects the other. So we want the well-being of each family member. So we all work together to make, in this case, the team that we have in front of us feel better, but we acknowledge that there's social, community, family situation that affects everyone. So that's what we cover in the family session. We set the stage for the work that we will be doing, right? And then we do the second session, which is identity, which is one of the core, the main important aspect of this treatment approach. And these are the objectives of the first session, the first individual session, the second in the protocol. So we want to connect with the teen, and we ask the adolescent in this in this engaged first session to engage, to define who they are, how they feel, and their reasons for leaving. And we also identify areas of adolescents' identity that may influence suicidality or may be in conflict with other aspects of themselves: family, religion, community, school, friends, all that. And we define adolescent therapeutic goals, and we assign the hope box. And the hope box, for those that don't know what is that, is match to the reasons for living. So when we discuss the reasons or motivations for living, we ask them to work on a hope box where they will put in a box or in a board things that represent what is important for them in their life, what keep them alive. If it's their family, they can put pictures of their family. If it's what they're gonna want to be in the future, if they want to travel the world, then just put pictures of the place they want to go, things like that. So keep them motivated. As part of this identity session, then we set the stage to explore different aspects of each teen. As you will see here, who I am. So we ask them to circle characteristic of themselves and then write reasons for living. And then the second page is about sexuality. The way that questions are phrased here are open-ended, as you could see, because we want them to define, not us, how they see themselves. Also, each day we have different new terms coming out, and we don't want to establish like labels of this or that. We want to establish a platform that could serve openly, and keep working. So we want the team to let us know what is their sexual orientation. Open. They can use the word they want, and then we can ask them, what do you mean by, or what can you describe me more about what means being pansexual, for example? And then, but we talk not just about sexual orientation, so what sexuality means to you, how are you comfortable with your sexuality, to know in which part of the identity development process they are, if they are still questioning, if they are if they came out already to themselves, if they're struggling, if they are in the where they are. So this question is very important because of that, and I will show you soon what are the identity development process that we are talking about. What do you like about the people you're attracted to? How do you behave or get close to a person you're attracted to? So we can talk about, and is there someone around? We never, of course, use any question like, do you have any girlfriend or a boyfriend, right? Assuming that they are from one or other sexual orientation. We keep it open, and that's a very important recommendation for anyone working with any person. You don't assume anything, you just ask openly so the person could say where they are. So because if not, we're just going with the heteronormative of assuming people's sexual orientation and gender. And that's, if you want to get something from this workshop, is not assume anything, don't go by the heteronormative, but just ask respectfully always, and give the person, the teen, the chance to define themselves, not us defining them. We talk about gender and we ask, what's your gender? Again, the same approach. We don't put trans, female, male, what's your gender? And there's a lot of different ways that teens these days are using to define themselves. And then where do you fall in your gender expression? And we explain, what are your pronouns? When we ask about where do you fall in your gender expression, we have this rainbow. So it says feminine, masculine, and other. So you see that it says less and more. So we ask them to make a mark. We start with feminine. So less feminine, feminine in the middle, or more feminine. And they could do so many different combinations of this. It's amazing. And this is the same for, again, it doesn't matter if it's a person that is straight or not, or with a diverse sexual orientation. People can have different expressions in terms of the way they present themselves, how they feminine they perceive they are, how masculine or other, which could be, let's say some have used like as other could be queer, less queer, more queer. And I'm using the word queer in a positive and affirmative way. I know that in the past, queer was used to criticize or as a meaningful mean word for the LGBTQ plus community, that's not the case. I'm using here this word that youth use themselves to refer them to themselves when they are part of the LGBTQ plus community. So continuous identity, we ask them, again, that's a page of sexuality, gender, but we also talk about likes, language, beliefs, right? So we want to know that, and that's what we explain. We explain everything from a developmental approach, like in which adolescent is a phase of discovery, and there's a lot of things that you discover about your identity, and we want to know where you're at in those discoveries. And sexuality and gender is two important ones of many other different aspects of yourself. So we ask about things you like, about language, again, because this is in US, so Latinx in US could speak language or English or any combination with different people. Beliefs, this is a very important one. We ask, do you have spiritual beliefs yourself? What do you believe in? Same with political beliefs or stand. What is it? Are your beliefs similar or different from your parents? This is very important, not just here, right? Because in many instances, it is a reality that we have seen here, that usually there are conflicts between what parents believe and what teens believe. And sometimes not. Let's say they are both have similar spiritual beliefs, but there is conflicts in terms about how they see sexuality or sexual orientation or gender, right? So we have a conversation about not just belief here. So when we talk about sexuality, we ask them, does your parents uh, acknowledge, understand your sexuality? Are they, does they know about your sexual orientation, about your gender identity, how comfortable, you know, and there's sort of different answers to this. There are kids that, teens that say explicitly no, they don't know and don't use those pronouns in front of my parents. They're very clear, and we ask them, you know, when see how, and we asked them, do you, what pronouns should I use in front of your parents? And many said, you know, that I should go by the pronouns that are in alliance with the gender assigned at birth. So if they are, and this is just a poor example, if they're called Maria, if that's the name, they say in front of my parents use she and her. And if they are trans male, they said, but with me is he or he, or if they are they, or if they're using they or them would be they and them. And sometimes we have the issue, right now we have kids in our enrolled in our study that is tricky for the clinicians, because with the kid, they use a different name that they use with the parents, right? Or one, like different, we have also different households, when one household knows about the gender identity and not the other, and they are in the process of also wanting to let know the other parents, but they don't know yet. And then the clinician has to make this transition. So, okay, I'm talking with this parent, I need to use this name, not the other, because I'm not in the place to disclose. We have to wait until the time that it comes that the teen is prepared to disclose this information. So we have to be very clear about that with the teen and go by what they want and what it's safe for them as well. So we have to clarify all that here, and we also ask them if they feel there's a conflict or a tension between any aspect of their identity and their family, their religious community, the school, because we know that the tensions are there. We discussed already the framework that we use, our theory. So we want to understand, acknowledge, and address those tensions since the beginning. So this is a very important discussion. Is the first individual session in which we can see that, and also let the team know that we can hear and that we're open, because we naturally talk about sexuality, about gender to any kid, any. So that's a way of affirming them, from my perspective, in a very powerful way. We also talk about race and ethnic group, and we ask, what does race mean to you? What do you like about your culture? And I will not get that much into this now because we need to keep talking about LGBTQ youth identities, but this is part of also what we discussed. We ask further questions when needed. These are just possible questions to do. Who you are attracted to physically or sexually, and understanding that it could be different physically from sexually, as the gender unicorn show, right? There's difference on that. We may also ask, with whom do you have a special emotional connection? How comfortable do you feel with your sexual orientation? Just to have an idea, if they said, for example, that they are not comfortable when we asked the question before, how comfortable they are with sexual orientation. If they are not, we can then like ask a little bit more. Are you unsatisfied, neutral, satisfied? How do you feel? If not, there's no need. This is just other ways of asking. And then we can also explore about sexual gender and ask about your gender, with whom you identify the most, exclusively masculine, both non-exclusively feminine, about your gender expression. How do you like to present yourself the most? How comfortable do you feel with your gender identity and expression, which are separate. So gender identity is one, gender expression is the other, two different aspects. So it should be apart, but just to make the slide simpler, I put it together. Thank you. Okay, so the LGBTQ plus identity development process is different, of course, and this is about specifically the coming out process and accepting, understanding, and coming out to others based on those authors that are there that have made some studies about this. So it's understand that the coming out process or the identity development process start within and go outside. So the person or the teen or everyone start questioning themselves about who they are, and seeing that there's something that may not be the same as other. So they start realizing that they are attracted to people of their own sex or own gender. And the question, and I'm talking now about using the example as if it's sexual orientation. Let me clarify that. I'm talking about sexual orientation right now. And then from that questioning, at some point, it may go to, and that's the phase called identity confusion. Then identity comparison is that the teens begins to recognize differences between other people and themselves, but not necessarily about an LGBTQ plus identity. And then the next step would be kind of when their self-perception as part of the queer community increase, and they begin to look for similar peer groups, and goes then by acceptance process, when they get more in contact with people of their same sexual orientation and dealing with negative thoughts and prejudice about themselves and their sexual orientation, and they go toward gaining a better attitude toward their sexual orientation and their closet, and they also go to identity pride, where they feel more positive, feel more comfortable about their sexuality and coming out to others. And then at the end, it could get up to feeling very comfortable, very proud and committed to maybe advocate for others and are out of the closet in most places. And I would just say this is just like faces that are seen in some people, not others. There's people that do not get to go from one phase straight to the other, or they come back and forth from one phase to the other. This is a continuous process, as I explained before, because the society is not, hey, we are all different, let's all, let's accept everyone as they is, and accepting that any possibility of sexual orientation and gender could be accepted. Then the process of coming out could be a back and forth one. Not everyone, again, this is a very individual process, but usually start within and go out, and also start usually with close friends that are perceived that they're going to be supportive, and then to supportive family members, and then usually the parents are the last in the line to get to know about their kids' sexual orientation and gender identity. And this is based on studies again, and seems to be a certain pattern. So I would say the two in the corners is kind of a broad way of explaining this process. So I gave that explanation before, just so people know here that it's not just exploring identity and that's it, just by exploring, making questions. You need to have a framework and understanding that this is a process, and you have to assess where the teen that you have in front of you is. Are they in the process of coming out to themselves? Are they still questioning? Does they have a lot of homophobia or internalized biphobia, transphobia? Where is it? What they are fighting inside of them? Or that's done, they are completely acknowledging their sexual orientation or gender identity. They are completely clear about who they are. Now they are in the coming out process to others, and that's the struggle. Nothing within is outside, and maybe they have already a few people around them that know, again, close friends or a few family members, and now they're going to talk to the parents, or they haven't talked to anyone, just themselves, and you're the first person they're going to talk to. That's why I'm presenting that. It couldn't be just asking for asking. We need to know, understand in which part of the process this person in front of us is. And again, acknowledging that it's completely normal to have internalized homophobia and a lot of phobias when we are in a world that all the time is presenting just heteronormative values. So saying that, we use this as an analogy that could be very helpful with LGBTQ plus youth. Sexual identity development or gender identity development as a road trip, depending of which specifically apply to the thing that you're talking to. So some of the trip, so it could be thought like that. Some trips could be fun and exciting. Other parts of the trip, in other parts of the trip, you may get lost and you may need to ask for help or directions, right? Sometimes you may feel very clear about where you're going, but not others. And you may have people supporting you on your journey, and sometimes you may feel alone. And so that's the analogy that was gave to us when we were developing this by one team that we were working with. And we can ask them to draw this map in a piece of paper, or they want to do it like an art or however they want, and we can ask, how has your trip been so far, right? And then we can talk about those different points in their identity development. Can you draw yours or talk about it, right? If you were to make a map of this metaphorical road trip, what stop would be on it? You can also show them video clips about the journey of other teens, like that they have been in their place, like It Gets Better. That's a campaign that have a lot of testimonies that could help on discussing how their experience may be similar or different from others, so they don't feel alone, so they can see that they're not the first in the world going through this. But obviously each experience, each person experience is completely valuable. The third session that we do, so we have covered, let me summarize here. We explain the first session is a family session. We provide the platform, the context. Then we go to the identity session where we talk only with a teen about different aspects of their identity, platform to know where they are, and then we do the chain analysis. This is the second individual session and the third in the protocol. And in the chain analysis, we establish through a chain analysis of problematic behavior, the relation between events, thoughts, emotions, and actions that unravel during a suicidal crisis, with particular emphasis on thoughts. And we define the problem from a socio-cognitive behavioral perspective, and we develop a personal emergency plan. So in the first one, we do a family emergency or family safety plan, like to set the base and kind of give us some space until we get to the individual one. Anyway, our teens, they just were discharged from the hospital, and we use here in the hospital that I work with a safety planning. So everyone is discharged with a safety plan. Uh, so we just review the safety plan that they have there. But at this point, we have the chance to kind of review again the safety plan that they did in the hospital, and to go like in deep, like if we are doing a detective work using a chain analysis. Can you please the next one? And I have to say, I mean, the chain analysis is some of the ideas that are taken from DBT, from Marsha Linehan. She talked about a chain analysis, and we kind of adapt that type of approach for the social cognitive in a kind of different way, but I mean, she was the one that first explained and provide this idea of a chain analysis. So ours look like this. This is the one that we developed for our study. So each circle is like an event, and the clouds are the thoughts, and we write down in the lines the emotions that are in each of these events. So this at the bottom, I forgot the name to that, like that's where when the suicidal crisis happened, right? So we are trying to ask, let's say that they attempt at night, since you wake up in the morning, what was the first thing you did? And then we write down that in the circle, and we ask them, what were the thoughts when you were eating breakfast, for example? How are you feeling? I feel chill. Okay, then what was the second thing that happened, important, that happened that day? If the second thing was, I got into a fight with my boyfriend. Okay, so what were the thoughts that you have at that point? What were the feelings? And we keep doing that and drawing arrows from one circle to the other, so we can have a map of what were the things that happened that day that led to the suicidal crisis. This is very helpful to understand what were the things specifically that brought that kind of push or trigger the event. Remember, we have like a contextual idea, because we do with the whole family the risk factor and resources kind of assessment with them as part of the therapy session. But individually, in one day when someone attempts, we can see specifically if there are any thoughts related to, I'm not accepted, I'm not loved, my mom or dad doesn't use my pronouns, like I went to the kitchen and they called me by my birth name instead of my new name. So those things are the things that you can see. What are the things happening that may be related in some way, if so, with their sexual orientation and gender? We do have had kids that one of the triggers for their suicidal crisis has been one parent not wanting to use their name, their new name. Again, I will use a very common example. Their name is Maria, and their new name is Jose, and one of the parents does not want to use Jose and keep using Maria, or keep using the she pronouns when he already expressed that they want them to approach him as he. This is an example, and those names are not real. So we can see there where the tensions are from the teen's perspective, and we can use that to go back again and do a treatment plan that is tailored specifically to this family, and know what we need to address with the parents, which will be the next seminar. And the thoughts, again, we can see if there's internalize homophobia and any of those thoughts. If in the daily life that brought that kid to the emergency room, there were triggers at school. If someone said something to them, if they have been bullied because of their identity, and what the tensions are. Again, this doesn't mean at all. We have had a lot of teens. I mean, I see them in my clinic, and there's 76 in our study. That doesn't mean that because your gender identity or your sexual orientation, anything related to that was present in the suicidal crisis. So we cannot assume that either, which will be a huge mistake. We need to assess and address and be open to understand what are the interactions, or if it's related to, for example, how they dress, and they don't say directly, but it's related to parents not accepting how they dress. So they're not accepting a group of friends because they feel that influence them to be who they are. All those things, you can see them more specifically through the chain analysis and use it for the treatment approach. So again, I'm sorry, this is in Spanish because for some reason I thought that this was a Spanish seminar. That is a personal emergency plan. The personal emergency plan is done with the chain analysis. So we see specifically what were the triggers in the situation, and then we ask what are the red flags, the risk, the red flags for you, like after seeing the chain analysis. And then it's like to have an insight on what happened. So it could be those red flags, could be how I see myself. If we see a lot of thoughts related to low self-esteem or self-criticizing themselves, we can see that pattern there. And of course, it may or may not be directly related to their sexual orientation or their gender identity, but if we use our approach, our treatment approach, and they're saying, I'm ugly, I feel bad about myself, I don't like me, I wish people could love me as I am, then you as clinician with this approach make the connection that something may be there that you need to keep exploring to work with this team. The second thing that is a safety plan, I mean, you can look online, there's a lot of safety plan. This is just the worksheet that we use, but you can look for what is that. We determine like activities that they could do to help them feel better, things that they could say to themselves, and people that they can approach. That's basically what happens. Safety plan. And then next, I want to say, and I need to, this is very important. Maybe this is my last slide for today. And why so important the chain analysis? This is cognitive restructuring. So we have in the chain analysis, we're seeing the pattern of thoughts that may be related to their suicidal crisis. We saw the events that trigger specifically the suicidal crisis. We know the family. We see how they interact in a family session. We hear how they explain the suicidal crisis. And then we have a lot of material to work with, right? So when we see all those thoughts that the teen have, then we use this approach, which is, again, this is a socio-cognitive CBT approach, right? So in terms of cognitive restructuring, we need to be aware that we have to ask maybe a further more or go more in deep than a regular CBT approach, in which a CBT approach you ask like, okay, so what's the negative thought? And maybe okay, so how can we, that's a negative thought, and then how can you change that thought to a positive thought, right? Like, and then you question that thought. So the process of questioning, my proposal is that the process of questioning for LGBTQ plus teens have to go beyond that. I mean, and this is not just mine, there's other papers out there that have present how to do cognitive restructurings with LGBTQ plus teens, but that's also, this is the approach that we use. So we ask, what are the beliefs or ideas some people have? We have to explore versus facts, right? So we have to acknowledge that there are social norms that not necessarily are true, because some people think it's true, that doesn't mean it's true. We have to separate what are those, right? What is that society is selling to us as true that not necessarily is. It is normal to have certain ideas, for example, think that being gay is bad or that I will go to hell is could be normalized because we were taught that, or we thought that it feels this, maybe I'm bad, or I'm in this situation where I feel so bad about myself and so much distress, so we can use what is going on in our world to explain that, in the sense, okay, if you're socialized that everything that is yellow is bad, then when you see something yellow, you will kind of reject that. So it's normal that in certain ways that you have internalized homophobia because of the socialization. So we need to get into that and explain more. The question is this true? Let's look for evidence, right? Again, social norms may be right or not. How do you know or prove that this is true or not true, right? So we have to look for evidence. We have to use, if it's necessary. Sometimes we don't even have to go to research to prove. There's a lot of information out there of positive role models for the LGBTQ community and youth and people that are good role models that we can use. And even in the campaign I talked to you about, like It Gets Better, that campaign, there are a lot of youth, like normal kids and teens that have gone through a difficult process, and now they feel different and better. They usually, every teen knows other teens or someone in their community that are good role models. Like there's a lot of LGBTQ alliance group at school where there are other teens that are also out. And I mean, they may not be out, but there are others that are out that they know. And then there's a lot of ideas about being LGBTQ that could be questioned using their own knowledge. But if that is not enough, then you can open it to other information that is out there, available for everyone. So I will have to stop here. This is the general approach about how to work with LGBTQ youth. It's impossible to cover everything. I would love to, but it's not possible. So I just hope that these ideas could help you on your work with LGBTQ youth. I will be talking next seminar about the approach with caregivers, but if there's anything that I cannot answer today that you put on the chat, I may think about that. I may be able to include it on the next one. So I will just open for 8 minutes of questions to see if there anything that I could provide more information.
Yes, thank you. Thank you, Dr. Duarte, for that excellent presentation and for sharing those resources. Yes, we would like to open it up to any questions the audience might have. I will start by maybe addressing this one question here. Are the sessions all family sessions, or do you see the adolescent first and then the family separate, then all together? So it's kind of the order, yeah, in which
Okay.
they will be seen, yeah.
Yeah, so as I explained, the first session is a family session, and that's the session to understand the suicidal crisis from the Socio-Cognitive Behavioral Therapy approach. So the first one is all together, and as I explained, we ask about how they understand the suicidal crisis. I mean, we first connect about how you get here, how a question about their family story, right? And we start introducing ourselves so they can imitate how we introduce ourselves and talk a little bit about themselves and about them as a family. And then we get to the suicidal crisis. So the first is a family session, and we do this family safety planning on that session. The second session is individual with the teen, which is the identity session I explained. The third session is individual, is the chain analysis. And then after that, I mean, I feel that these 3 sessions are the map, or we have on those first 3 sessions as much as we need to see how the treatment should be tailored specifically for this family. But again, we follow then the protocol of the other sessions that we have, that there is a combination of parent sessions. So I would say the next one is not family again, it's just parents only. So we have the chance to touch base with the parents alone about the how they feel about the first family session, how they feel about their teens issues without them in the session, so they can feel free to say the things that they may not feel comfortable saying in front of the teen. And that's, I will touch base and talk a little bit more about the family sessions and parent sessions in the next seminar.
Okay.
So, but overall, as a protocol, there's a combination of individual, parent, and family sessions, but most of the sessions are with the team.
Excellent, Dr. Duarte. I think we have time for one more question. And before I do that, I would like to remind everyone, in the meantime, you will get an evaluation form through email, but here's also a QR code which you can scan. These evaluations are really important for us. This way we get these great speakers and panelists as Dr. Duarte. So this question is addressed by Joanna Garcia, asking, how do you handle a client living with multiple generations of family in the same house who may have different levels of acceptance as well as different ideas about therapy?
That's a great question. So we do see families that I can think just right now we have, for example, one of the grandparents, parent and the kid in one same household, right? And there also other household where the teen goes every other week. So it gets complicated because as she acknowledged, every parent could be in a different place about accepting. So when I see the parents first, like the parent session is for anyone that has a discipline role or a caregiver role, right? So if the grandma, for example, shares that responsibility with the parent, when I have the next parent session, I will ask them to be together in that session. If for any reason they don't want to participate because they don't believe in therapy, they don't like it, they don't want to, I mean, we work with what we have. I will not stop treatment because one parent does not want to show up or one grandparent. So I work with what we have. So we keep going. We meet, for example, with the mom in this case, which usually more moms in the sessions, and we get her perspective about where the other family members are, if that's a disclosed, I'm assuming this is a known issue, right? That parents may be in different place about someone's sexual orientation or gender identity, right? And then the approach that we have used, that I will talk more about this in the next seminar, is that in some cases we have addressed certain things with them together, and there's certain moments that we need to meet apart. For example, if we feel that we need an individual session with the grandma to hear her and explain her at her own pace, we will do it, right? And the ones that we can have together, we have it together. I mean, we have had a mom and a dad that they are in different places about accepting, and we provide a platform of understanding. This will be again covered in the next seminar, an approach that letting them know, all of them, that it's okay if they're in different paces. There is a process of adjustment, that not everyone processes the same, that, so we give them permission to be in different places, so to avoid more conflict between them because they are in different places, right? So we want to decrease the tensions. So, but we like validate any effort they are doing to validate and show love to their team. So that's a, you know, like a very overall way of addressing this issue. But we have had, yes, situations where they are in different places. So basically that we do family together where we can talk together, we do it. If they need a separate space, we do it, and we acknowledge that everyone will be, and it's okay to be in different places. We need to let them have their own process.
Thank you very much. I think that will do it for our time today, but I will encourage everyone to join us again on July 6th. As Dr. Duarte mentioned, you will be covering the aspect of caregivers in terms of these relationships. Thank you again for this wonderful resources, presentation, and informative presentation. Yeah, I will leave it there for everyone, and thank you, and hope to see you again soon. Thanks.